Next up is MOBE. So for those of you maybe who aren't familiar with MOBE, MOBE focuses on your multi-chronics and those that, honestly are pretty high cost, but also very overwhelmed with care because they're dealing with multiple aspects and sometimes competing solutions. So with that, I'm going to welcome the MOBE team. So.
There we are. Hello, everyone. My name is Jake with MOBE. Easy name to remember. Not Jake from State Farm, Jake with MOBE. I did wear khakis today, so we got you covered there. We saved the best for last, which means there's one more after me. I'm excited to share more about MOBE with you today. We're not the giant white whale or the 90s artists. We take an innovative approach to chronic condition management. And we're your neighbors. I'm from Minnesota, where we're headquartered, like a good neighbor. 2 State Farm references. I should start charging those guys. Like I said, we take an innovative approach to chronic condition management. We've been at it for the last dozen years. We started out serving large commercial, fully insured health plans, cut our teeth on that line of business, ran our randomized control trials, got our validations from actuarial firms like Milliman, Havarti Risk, and we've taken that same great model and we've deployed it to the self-funded market. Our threshold is 2,000 adult members. That's inclusive of employees and adult dependents. So think of that as you have groups in mind. We still do our health plan line of business. On the commercial side, we do some Medicare work as well, and then the self-funded business. And really the reason we exist, the problem we solve, has to do with individuals who are struggling with multiple chronic conditions. Recent data from the CDC says that now over 50% of US adults have multiple chronic conditions. We all sit here and nod our heads and yeah, the math adds up on that, but that's insane. Over 50% of US adults have multiple chronic conditions. Something isn't working. What's even more surprising is we see that same trend within young adults. Over the last decade, a 25% increase in young adults struggling with multiple chronic conditions. And you all know the challenges that result from this: rising healthcare costs, overwhelmed employees, they're difficult to engage. There's a lot going on. Ultimately, where this shows up most is not just in the specific conditions. If you were to take those 4 or 5 conditions out and plop another 4 or 5 in there, you'd have a lot of the same participant challenges: financial strain, stress, sleep issues, weight management issues. The list goes on. And ultimately, it shows up within the utilization patterns for these multi-chronic individuals. These folks are in and out of the healthcare system: doctor's office biweekly, pharmacy weekly, longer hospital stays, frequent ER visits, lots of providers, lots of prescriptions. They're stuck on this hamster wheel within the system, and they're not getting the resolution that they seek. Furthermore, this problem is only perpetuated because as employers and consultant teams, we're forced to focus on high-cost, high-risk individuals. And that's all fine and good. We need to do that. But in doing so, we're missing this mid-tier claimant, this rising risk individual who eventually becomes this high-cost, high-risk participant without intervention. It's been touched on in a few of the presentations already, but the healthcare system isn't set up to help these individuals. It's a volume game, right? How many people can we get through that provider's door? Over 80% of doctor's appointments now end in a new prescription. It's not helping the problem. It's putting a Band-Aid on it. And I could probably ask any one of you to open your email inbox, and you've probably got several marketing emails from all the singular focus point solutions that exist in the marketplace today. It's a busy, crowded space. Over 1,200 different point solutions exist in the marketplace. No wonder it's really hard to solve this problem for a multi-chronic individual. So what do we do about it? Well, that's where MOBE comes into play. We identify this segment of the population differently. We look at those utilization patterns. We're not identifying the population we focus on based on specific conditions, based on certain risk levels or cost levels. We're looking specifically at those utilization patterns within the healthcare system through claims data. I'll touch more on that in a little bit. Once we identify the population, we invest heavily to engage those individuals as a human, not as a diagnosis. And when you pair that message of value front and center for a human and what's valuable to them, it's really easy to connect them and help them take the next step appropriately. How do we take that next step? Well, we connect them with our health guides and licensed clinical pharmacists. That guide, that pharmacist, co-create a health improvement plan, considering that whole healthcare picture, all aspects of their chronic conditions and really optimizing lifestyle behavior change and medication optimization, that blend that allows us to effectively move those individuals forward. Thus creating better health outcomes, reducing utilization within the healthcare system, and creating savings. 100% fees at risk model that I'll walk you through. On average, we save 7.5% savings year one against this segment. I'll dive into more of each of these aspects as we go. I mentioned it starts with population identification. We take in claims data to do this. MOBE partners with your carriers. We take in 3 to 4 years worth of historical claims data. We handle any fees associated with that. And through that data, we're looking at medical claims, RX claims, eligibility files, and we're identifying roughly 20% of any given employer's population. Again, inclusive of employees and adult dependents. Some of the characteristics I talked about already. These folks, again, they're in and out of the healthcare system, not yet your high cost claimant. On average, they're costing anywhere from $18,000, $20,000, $22,000 a year, but trending higher year over year. 9, 10 different providers, 15 to 16 different prescribed medications. Over 50% of this population has 4 or more chronic conditions. Over 80% has 2 or more. So it's really that focus on that multi-chronic individual. Although MOBE focuses on this segment of the population, anyone on the plan can opt into MOBE that's an adult. We're not targeting our outreach or performance efforts against that segment because we know these are the individuals that need help, but they're certainly welcome to participate within MOBE. Now, engagement. Everyone asks, well, how do you engage these individuals? It's $1 million question, right? And there's no one thing that drives engagement. It's a combination of things deployed in a very specific way. Starts with the data. When we're getting those claims data feeds, that long-term historical data and those ongoing feeds, it helps us identify who needs the help and when they need it most. That population is already primed to participate. They're just stuck within the healthcare system. They're on that hamster wheel. They're seeking resolution. They're just not finding it. So the data is a big piece of what we do. We launch a 16-week launch campaign full of engagement strategies, all the usual suspects here, direct mail, emails, outbound phone calls. We fully fund incentives that we send out to the MOBE selected population, something like a $50 Amazon gift card once they complete that first phone call with a guide or pharmacist. We have additional incentives sprinkled in throughout the program, again, all fully funded by MOBE. We have various campaigns that we launch throughout the performance year as we're working with the population. We partner with clients on internal signage at various factory sites for manufacturers and things of that nature. And then one of the biggest things that helps drive engagement for us is we have a whole department called an engagement department. It's full of actual humans, not chatbots, actual humans. And turns out 2026, humans still do like humans. And these engagement specialists, they're heavily trained on tactics of motivational interviewing and fundamentals of influence. When they connect with one of these participants, 70% of the time that results in scheduling a call with a guide or a pharmacist. Again, placing that message of value. You're not going to a diabetic and saying, hey, we need to lower your weight and get your A1C under control. No, what's important to you as an individual? You may have diabetes, but maybe it's 3, 4, 5 on the list. You're a single mom, you work 2 jobs, you can't sleep at night. You just want to go for a walk around the block, but even that's hard. Let's start there. Let's gain that trust so that you can give us the authority to then lead you and help you move forward. Big piece of our engagement strategy. We drive 30% year one, robustly defined as actively working within our program, ongoing conversations with their guide and pharmacists, work within our digital app through that as well. And ultimately, once that individual is engaged, that's really where the rubber meets the road, connecting with our guides and pharmacists. Our guides and pharmacists, full-time MOBE employees, our guides come from a wide variety of clinical backgrounds. Think OT, PT, nurses, chiropractors, et cetera. Pharmacists, PharmDs, many of them hold additional board certifications in various pharmacy specialties. And it's really through the work of that guide and that pharmacist co-creating a health improvement plan specific to the individual that allows our participants to move forward effectively. We use self-perception of health surveys. We work with that individual ongoing. There's no end stage or graduation to our program. On average, participants spend about 6 to 8 months actively working with their guide telephonically, about a half-hour call every week. But we're always there. That cadence and frequency can change over time. We typically contract with clients for 3 years. And if a new diagnosis pops up, a change in the medication history, we're seeing that through the claims data. So they can pick up those conversations again as they're working with that guide and pharmacist. The value here is that one-to-one relationship. It really is the gift of time that we spend with these individuals. It's the same guide, the same pharmacist. We offer Spanish and English speaking guides and pharmacists, as well as engagement specialists. And the power is really in that one-to-one valuable, trusted relationship that's ongoing to help these individuals in terms of everything they have going on within their healthcare picture. I want to touch on the work of our pharmacists a little bit more. The guide work is really important, but a lot of times the first domino to fall for someone to make a lifestyle behavior change is through medication optimization. Our pharmacists don't prescribe. That's intentional and on purpose. These folks have enough going on within their healthcare picture. We don't need to add another prescriber, but we need to optimize what that picture looks like. Our pharmacists are providing what's called comprehensive medication management. This is layers above and beyond traditional MTM offerings. We're not looking at only prescribed medications, but also over-the-counters, supplements, herbals, topical medications. And we're making those recommendations back to not only the participant, but to the various providers for that participant as well. Very high adoption rate, 95% plus. There's a lot of follow-up and follow-through here. This isn't a one-and-done consult or call. Again, it's the gift of time and that ongoing relationship that we're able to uncover these things. A lot of the recommendations are made on things like cost, access, safety, side effects, dosage. If someone's taking a prescribed medication and maybe they're taking a baby aspirin every day and there's a weird interaction there. Well, uncovering those things, again, allows that first domino to fall so that participant can move forward effectively. A lot of time spent with these individuals. I want to bring it to life a little bit here with a participant example. You see Angela here. She's a MOBE participant. On the right-hand side of the screen, you can see the fragmented approach she was experiencing prior to working with MOBE. She has those 4 different conditions across the top that she's struggling with. She had a 1-year delay in a type 2 diabetes diagnosis, a GLP-1 that sent her to the ER, lots of medication in the picture, lots of providers in the picture. You can imagine how frustrating it was for Angela, bouncing around like a ping pong ball within the healthcare system, but not getting better. She actually failed out of a digital-only weight loss solution that was sponsored by her employer. After 10 weeks, she failed out of it. She couldn't keep the weight off. That was her main goal. She wanted to lose weight. She couldn't keep the weight off. When she came to MOBE, lo and behold, guess what one of the side effects was of one of the medications she was taking? Weight gain. Of course, she couldn't keep the weight off. Things were working against her and they weren't put together in a way that allowed her to move forward. So when we started working with Angela, we were able to optimize that medication picture. Again, our goal isn't to take away medications. It's really meant to optimize that picture so that that participant can best move forward on the best foot. We lowered some of the clinical things when it comes to A1C, kidney function improved, her headaches decreased, and guess what? She started losing weight. And when you think about Angela, she's one of thousands of MOBE participants, but when someone like Angela starts showing up to work as the best version of themselves, amazing things happen, not only at work, but also in life. And I think that's the important thing to note here with that profoundly human approach. If you think about where we fit within the benefits ecosystem, certainly questions around this, right? Well, where does this program fit, or how does it work with all my other programs? Upon implementation with any client, we take an inventory of all the solutions and things that that employer client offers. And where MOBE fits, if you think about us sitting outside the healthcare system, we have our arms wrapped around this multi-chronic individual, helping them from a whole person perspective. Where we interact with the healthcare system is through our recommendations made back to the providers for that participant. We're not a navigator, but we never want to be the end of the road for someone. So we'll complement navigators well, the Quantums, accolades of the world. We're not here to replace the PCP. We're here to complement that relationship. We'll refer folks into virtual care and things of that nature. And then if the employer offers specialty solutions, EAP mental health resources, cancer care solutions, fertility support, we want to be able to help that participant. And as part of that inventory, we're reporting and tracking all of those referrals that we make as well. Last slide, the savings. This one's always important, right? Everyone wants to know, well, what are the savings? How do you measure that? One of the founding principles of our founders at MOBE was not to add cost to the healthcare system. We want to leave people better than we found them and create savings as a result of the improved health outcomes that we drive. So we have a model here, 100% fees at risk across the categories of actual claims cost savings, participant engagement, and improvement in lifestyle metrics. 100% fees at risk across this model. question you might ask is, well, how do you measure claims cost savings? It's an actuarial exercise. So we'll look at plan design, trend, truncation rules, outlier caps. I'm sounding like an actuary up here. This is pretty cool. I'm not an actuary. We'll look at all of that. We'll sit down with you, the benefits team, the consultant team, your actuaries, and we'll align on that benchmark for this MOBE selected population. So that roughly 20% we've identified, what do we anticipate them costing in the next 12 months? Once we've collaborated and aligned on that, we'll agree on that benchmark, run our program for 12 months, snap the chalk line at 12 months, allow for a few months of claims run out, and measure our performance back against that benchmark. Did we actually create the savings or did we not? A few different ways to bill through this model. We can charge your classic admin PM against the MOBE selected population and then true up at the end of the year. Or we can offer claims-based billing as well. So you can see those savings from the same bucket that you pay from. So if you remember anything about MOBE, aside from my beautiful face, it's that we identify the population differently based on utilization patterns. We get a multi-chronic individual who's a mid-tier claimant, rising risk. We invest heavily to engage that individual through a profoundly human approach, and we work with them from a whole person perspective, blending lifestyle behavior change, medication optimization to drive savings, improve health outcomes, and leave people better than we found them. Thank you, and I'd love any questions.
I'm curious about how do you get the buy-in by the PCPs to work with your pharmacists? How does that work?
Yeah, so when we start working with an employer client, we want to take in an inventory, everything that they offer, right? We sit outside the healthcare system, so we're not stepping on the toes of the PCP. That employee may go to their PCP and say, hey, I'm working with this great program called MOBE. They're working on some lifestyle stuff. The pharmacist is the one who's going to interact with those PCPs. So there's a lot of good follow-up and follow-through that happens there. Again, not only prescribed medications, but things outside of that, right? And so a lot of times the feedback we get from the PCPs is, oh my gosh, I had no idea that Jake was also taking that supplement with this. Had I known, I wouldn't have recommended that dose. Yeah, let's go ahead and change it. And when we're following up, provider offices, 2026, they still like fax. So we're faxing, we're emailing, we're following up with phone calls and having the conversation. And if you think about the multi-chronic individual, 9-10 different providers, there's a lot that can fall through the gaps there. So the feedback is often warmly received, and it's more of, oh my gosh, I had no idea, or had I known, I would have done this instead, or thank you for letting me know. Yeah, let's adjust it. Yep, I see where you're coming from. That makes sense. Those types of conversations.
So the concept is introduced by the patient to their PCP.
We are making the recommendations back. So we'll actually reach out to the PCP.
Okay.
Yep.
Okay. Thank you.
Yeah.
I could go into a long diatribe about this too, but I think PCPs really need this help because they take one class in medical school on pharmacology. I just did a big research project for a national organization. And this is an area where we all think it's being captured, but it's not. It's not being captured by the PBM. It's not being captured at Walmart where they get all their prescriptions. It's not even being captured at some of the hospitals. So, when you have a pharmacist looking at this, and I think MOBE also uses some AI behind the scenes too, to aggregate all those prescriptions together to point out where these things happen. Because sometimes people can go in, like you said, multiple doctors. The other thing too, I've talked to several physicians, where they get most of their information about new pharmacies or pharmaceuticals entering the market from their pharmaceutical rep.
Yeah.
So they don't have any unbiased kind of approach. So they're prescribing things out of the best interest, but they don't know if that medication has a serious interaction with others.
Well, I think it comes back to the gift of time spent with an individual to intimately know, what are you taking? Why are you taking it? Why was this prescribed? Why are you taking this supplement? I was talking with my grandma last week and she's like, I started taking vitamin D. Why? Oh, I heard it was good. Did you check with your doctor? Nope. It might not be good, right? And so having the time to chat with someone who knows the ins and outs of your specific set of circumstances is really helpful. And our PCPs, they would love to spend this time with the individual, that the healthcare system isn't set up to help that multi-chronic person achieve success, because with your PCP, you might get 7, 8, 9 minutes if you're lucky. And then, okay, we'll see you next year. Here's this prescription. Good luck. Any other questions?
I have one. So just kind of going back to your financial model, I just want to make sure I understand. Are you actually doing the claims cost savings on the identified population? And so is it a true cohort kind of situation? We're looking at their costs and then saying, okay, right, we're actually saving money on this population?
Yep, that's right. We're looking specifically at the MOBE identified population, and it's all tied back to claims line level detail. So we're getting the ongoing claims feeds from the PBMs, the carriers, and then we're also doing that actuarial exercise on the front end to align and agree upon that benchmark. And then, of course, adjusting if there's any material changes, throughout the year, or changes in plan design or carrier migration, or maybe that employer client implemented an RX savings program. All those things come up.